the ICU for allowing us to come and visit with you guys today and present some topics of interest to us that I think present a lot of good thoughts, dialogue, and discussion. The topics today are hot topics in palliative care and ethics, and the reality is we presented this at the grand rounds for the physicians at the end of September, and I think we could have actually visited about it for at least 2 hours. So we'd like to present the same topics to you today. Dr. Andrea Beyer unfortunately was ill today, and so Glenn Duggett, a lot of you know Glenn, he is the chaplain for the palliative care program. You want to introduce yourself?
Hi, I'm Glenn. I'm the chaplain with palliative care, and I also do, I'm the chaplain for home hospice and the hospice house down here. We have one up north too, so.
And Geneva?
I'm Geneva. I'm the mental health counselor for palliative care.
So as part of the roles of palliative care, we also work very closely with the ethics committee here in the organization. The ethics committee has been a formal structure forever in Rapid City Regional Hospital. We look at the changing times of healthcare. Some of the ethical dilemmas of 10 years ago in healthcare are no longer ethical dilemmas, and new topics are always coming up in healthcare that pose many challenges to the providers and to the healthcare workers of today, and of course also to families and patients. If you ever have an ethics challenge concerning patients that you want to talk about, it's best that they are not in a crisis situation, but one where plans and development of plans and care plans can be made. Just let us know and we'd be glad to work with you, take those cases to the ethics committee, and help in problem solving with some of the ethical dilemmas that are out there today. I'd like to share an ethics case that was presented probably 3 months ago to the committee. Actually, it was a patient of Dr. Beyer's, and I'm going to have Geneva and Glenn help fill in the blanks if there are blanks that I've missed, because Andrea is ill today. Dr. Beyer presented a case, and it was Mr. Jones, and he was a 70-year-old patient with significant COPD. With, of course, heavy tobacco use. And this gentleman had been hospitalized several times. He was acutely aware of his situation, his surroundings. He was not at a point in his healthcare state that qualified him for hospice, end-of-life care, because he was not within a 6-month window of passing away. The palliative team was asked to consult him on goals of care, and in essence, he was very clear with Andrea and the team that he plainly did not want to live anymore. And his family agreed upon this with him, and he asked the physician, Dr. Andrea Beyer, to assist in his suicide. And of course, this is a significant ethical dilemma for physicians and nurses today. I think many times at the bedside you do hear, "I just want to die and help me die," and words like that become very difficult to deal with. This gentleman asked for an order for his morphine, of which of course Dr. Beyer did not engage in or prescribe, but he knew what meds he was on, and at one point he did ask the nurses to provide him some morphine for comfort, and then he himself took his oxygen off and passed away. This was a very difficult case, and the team really wrestled with this. There was no assisted suicide by the physician, but the reality is the patient took it upon himself to do what he wanted to do. And these are becoming bigger ethical dilemmas in today's world, not only at the bedside and acute care arenas, but throughout healthcare in general. And so I open it up at this point, first of all, for your feelings on a case like this, for your thoughts, maybe for some of your experiences that you have had in relationship to cases like this, and what we as healthcare providers can do to work through these cases, what has worked in the past for you. Just open it up to dialogue.
It's a huge issue, I mean.
It's a huge issue.
So my question is, how much morphine?
You know, I do not know what the dose was. I know it was within limits, appropriate limits.
Well, and the patient was on comfort care, and, you know, in comfort care in the home or hospice in the home, you know, if a patient who normally relies on oxygen, they're free, whatever their comfort level is, to use that oxygen or not to use it. And so I think Andrea wrestled with, like, should we have made him wear that oxygen? And then is that counter to, like, his autonomy to be able to, like, dictate to him, should you or should not you use it? And he said to Geneva and Dr. Beyer, I'm gonna die today, is that what he said? Yeah. You know, so he was pretty adamant on it. I think he knew if he didn't have his oxygen that, you know, his stats were gonna plummet and he's probably gonna pass away. And his family was very supportive of all this. There wasn't a lot of ethical stuff within the family as far as his decision to want to do that. And so, you know, for me, it's not a clear-cut case. I know other people have wrestled with it more than I have. But I mean, if he was at home on hospice and not in the context of acute care medicine, we may not have even thought.
So he was
about
on
it.
comfort measures.
Mm-hmm.
Well, that's what we do. I mean, that's what we do here in the hospital. We give them Ativan, we give them fentanyl, and we extubate them.
Mm-hmm.
Of course, they're going to have respiratory depression. I mean, but at the same time, they need to be made comfortable. We can't let them sit there and struggle either.
I think the difference with this case is he had a deliberate plan.
Mm-hmm.
He had a very deliberate plan.
So I think for
But
my-
isn't it a deliberate plan for the family when they decide to do comfort measures when we're extubating? I mean, truly.
How do you, can you talk a little bit about how do you not qualify for hospice, but you qualify for comfort care?
You bet. It's a real tough topic. It's driven through Medicare rules and regulations. And so if the prediction, and it's only prediction by the physician based on very, very lengthy, tedious criteria through Medicare, that the patient will pass away within 6 months, then they qualify for hospice. And those are Medicare standards. If they do not qualify for hospice, or they choose not to use hospice, they can be a DNR, of course, which oftentimes gets a little bit nebulous with comfort care. They are not the same thing. But they sometimes get put on comfort care just because they don't qualify for hospice, and sometimes they go home on comfort care. Yes.
Is that considered a suicide within the hospital?
Is that considered suicide within the hospital? No, and that was part of the discussion of the committee. And that is part of the ethics that we face moving forward in our healthcare systems is, and those are the struggling questions that we face going forward. The other piece of this that is struggling right now in our healthcare systems across the United States is the legislation in many states being looked at and already passed of dying with dignity or physician-assisted suicide. And I believe there are 8 states now that have formalized legislation and passed legislation on physician-assisted suicide or dying with dignity. And so that's causing a lot of discussion, and it's good discussion, and it's healthy discussion within our healthcare systems. Is this the right thing? Is it an option? Is it an okay option? And the reality is states are legislating it to say, yes, indeed it is. Now, with death with dignity or assisted suicide, there are very specific parameters that physicians have to follow, and they are detailed and well spelled out within the state legislation process. And I am not the one that can speak best to those, but it isn't as if they can order anything. There's a lot of psychological testing that needs to be done. There are certain parameters, certain things that have got to be considered before a patient would qualify for assisted suicide.
As I understand it, the patient has to meet Medicare hospice guidelines. And so, you know, if, for instance, if I'm diagnosed with ALS today, I can't say, give me something and I want to die. I have to be within hospice guidelines.
It's like that 6 month
Right.
expectancy.
Yeah, and like Marcia said, from the understanding from other states, they go through psychological testing, all sorts of things to make sure that they are within the realm to make that decision on their own.
So this person that you were speaking of in your excerpt there, was he a hospice patient?
No,
No.
we did not qualify
He
for
was
hospice.
just within that facility and had said that they had made him a DNR and that he didn't really want to, put him on comfort cares. So ultimately, they knew, but just because of the fact that he's within the facility makes it because kind of like he said, if he were in his own home, but because he's still here in the facility, that makes it a kind of a medical.
It makes it a
assist
medical
or
question,
something.
yeah. Nobody did anything wrong.
Right.
But it does raise the medical question of patients are beginning to ask their caregivers and the physicians to assist them to die. And where do we take a stand on that?
Where's the cutoff? Is that
Where's the cutoff? Yeah.
identified?
And so often in the ICU setting, we see the exact opposite because we know that patient is not going to survive, yet everyone's insisting on doing everything to keep the patient ventilated, to keep doing this and this and this and that. You know, I think the ethics committee is a little underutilized as far as addressing those issues.
I think you guys are faced with some really challenging situations. And I know sometimes the patient wants to die and the family does not want them to die. And in the state of South Dakota, there are a lot of legal boundaries with who can make that decision at this point, especially if the patient is unresponsive. And of course, it goes back to the family for decision-making at that point. But what can we do as a healthcare system as families wrestle with that end of life and they don't want to let them go? What kinds of things can we do to help see that maybe early on, or to get the right people to help those families at the time? What other things can you see that we can do to help?
Have a better chaplain service.
Yeah.
You know, patients, I'm sorry, they die at night, they die on weekends, and we have no support.
Yep. Do you want to address that, Glenn, of what you've experienced in other healthcare facilities?
Have better chaplain services.
Better chaplaincy?
chaplain.
Yeah.
Well, so I did my training at Level 1 Trauma Center in Denver, and we had 5 full-time staff chaplains, so we were 24-hour coverage in the hospital, 365, and then we had anywhere from 10 to 15 students at any time who were going through their supervisory or their chaplaincy education. So we had anywhere from 10 to 20 chaplains at a time who could assist with patient support and things like that. We also had a palliative care chaplain who was specifically worked with the palliative care team. And I mean, I think you're totally right, but that's a biased opinion, that we need more support. I mean, Jill basically runs this place on her own. And I step in with her in the acute care setting if she needs me to and when I can. But I'm usually with the palliative care team or with hospice. And so, I think, personally, I think it's like, that can be one part of a larger way that we move forward as far as providing whole person care, wraparound care for our patients and their families. I think also Dr. Simmons with the USD School of Medicine here in town lately has been talking a lot about having, like, providers and nurses and all of us in medical care having the courage to speak up with families, to be present with them, to say no when we feel like we need to, and to say yes when we feel like we need to. And I think encouraging a culture where providers, bedside nurses, everybody has the support where they feel like they could say, I don't feel like this is something that we can do ethically or morally. I can help you get the support that you think you need, or we can have a conversation about what it is, that's driving this kind of, like, for instance, with a patient who is, medically we pretty much know that they're, have a very low probability of survival of something, but the family's pushing. I think ethically, like, the ethics committee could be helpful in those things, but I think also finding a way to infuse those conversations in everything that we do and provide space for those families to really wrestle with what it is that they're actually getting at. I mean, I think coming from, like, a spiritual care background, a lot of those decisions that people are making, we see them every day, and this is a new experience for them. So finding out a way that we can take care of ourselves and be present to that while also allowing a family, even though we feel like we have a short amount of time to do that, to make sure that the patient doesn't suffer in whatever way we define suffering. But finding a way to create a space where we have a culture where those conversations can happen without our own anxiety about what's happening kind of coloring the whole kind of experience. I think having more spiritual support, because a lot of what I do every day is supporting staff. I think it's hard sometimes when we're trying to live into our own ethics and morals as healthcare providers, and then we get asked to do things sometimes that we don't think is right, or we're stopped from doing something that we think is right. And I think a lot of what I do, and a lot of what Jill does, and a lot of what Diane does when she's here, is support y'all. And I think if we had more support, if we had more professionally trained chaplains, we could be a better asset to you.
Well, sometimes you just need that extra, like prime example, and we brought this up, unfortunately, Nick is gone, but that was one of his challenges, was to learn to get us some more support, because we had a woman in the ICU whose son was dying, and we had all told her, we talked to her, the physician had talked to her, she just needed a chaplain to tell her it was okay. And I finally lied to the priest and said she was Catholic so I could get somebody over here.
Which you shouldn't have to do, right?
Yeah, but I'm Catholic and I know they'll come.
Well, that's right.
So,
Unfortunately, that's what happens because
Yeah.
we only have the Catholic priest on call.
Yep.
So more often than not.
We just lie, and then we have to go to
love
confession
and
about
just
it.
get somebody here.
I
So
think
I
you're
think-
probably okay.
Oh, no, I've been reprimanded more than once.
Yeah, some of them are very good about coming, but then some of them will call and follow up and say that that family was not Catholic.
That's right. They're getting hip.
And so I guess to navigate that world is just, it's kind of a case by case.
Yeah.
I wanted to ask a question as far as like caregiver and to support them in that conversation. Over the weekend, we had an example where the patient was in the ICU during round.
But, sometimes you just have to do that, and all she needed was someone to read her prayers too. And I'm like, okay, I can read them. She goes, but you're Catholic. I said, I don't care, Catholic, Lutheran, Protestant, whatever. You have a prayer book and you need them read, I'll read them. But there's some people that don't have that capability, Some people don't feel comfortable enough to do that.
Some areas use the parish nurses for that role, the parish nurses of the community. And maybe that's a resource that we can reach out to. I think the key is, it's seemingly at 12:30 at night. It's
Right.
seemingly at 3 o'clock in the morning. And
on
it's
the
very,
weekends.
it's very hard to watch these families walk out the front door by themselves. It's
Yep.
extremely difficult.
Especially when you know that the family, so the patient's had a bad event, and personally, you know, taking care of patients who code and we know that the prognosis isn't good and we need to withdraw cares, or the family is going to witness more codes, because that's the road we're going down. But they don't wanna make the patient a DNR until they see that they've had last rites, and they want us to continue life-saving measures until that's been done. And you're absolutely correct, it happens at the latest hour of the night, where it makes the night the longest. And then that patient and the family end up enduring more suffering because they're struggling like spiritually and with what's happening in that situation, because they don't feel good about like letting them go without like last rites and stuff like that. And so then as the caregiver, we keep this person alive, or try, code them, you know, put endless amount of resources and blood and all this kind of stuff that we know is futile, and that's ethically wrong to me too. Knowing that why are we transfusing if we know, you know, we're waiting on a check. So that's hard.
It
Or
is.
they're waiting for that check to come in.
Yes.
Oh, we gotta stay alive 3 more days.
That's very hard to hear.
I want to make sure and come back, no.
Yeah. Sorry, we got this new fancy phone and I don't know how to silence it. Anyways, this example was, the patient was in the ICU this weekend. During rounds that day, the bedside nurse had brought up that we need to discuss code status, because she had got the impression that the family kind of was ready for that maybe, and that the patient was kind of continuing to decline. The physician during the day said, no, I don't feel like that's appropriate. So she was kind of just trucking along, like we were just gonna kind of make it through. Well, that night she kind of took a turn for the worse, and luckily the nocturnist intensivist had a very good conversation with the family, and we avoided a code situation. We did have to temporary face externally shortly, and as soon as we started doing that, the family was like, no, we're not doing this any further. But same thing came up. I was trying to call the priest. I made 4 different phone calls, was never able to get a hold of them. And it's really difficult for us, even as coordinators, to try to assist in that, because there's a lot of churches that you'll call and it just goes to a voicemail. And unless you know somebody personally, you just can't really get over that barrier. And I felt very badly, because this family, on one hand, you know, they allowed her to just go naturally, and it was not as traumatic of an event, and they were all there. But they missed out that piece of wanting to do last rites, and you know, they didn't mention anything. I think they felt okay about it, but I couldn't help feeling like we kind of did a disservice, A, by not addressing it when it was probably more appropriate during the daytime, and we would have had a better chance of getting spiritual support up there. And instead, it got pushed off till the middle of the night, and she, you know, passed away shortly before midnight. And I think caregivers, nurses at the bedside really struggle with that of, I want to say something, but I'm shut down by a provider or the rest of the team, or, you know.
And I think when patients are admitted, right, there's always a question, are there any spiritual needs? And I think in a way, you know, we maybe just kind of pass over that, like we may ask it, but maybe in the intensive care unit, we need to say, you know, this person here is very ill. Would you like to have a chaplain visit, a priest visit, your minister from your church? Is there a phone call that we can make? And I don't know if that's extra work, you know, it's just a thought there.
I think we're hesitant to do that because we know there's no support. We can offer that, but when you can't call and get any help,
Yeah.
But
what's the
if
point?
If it is
Right.
during the daytime, you know, yes, granted.
When they get there at the
In the middle of the
beginning,
night.
Yeah.
they
Right,
just let the
right.
family know, hey, do you have a family
Minister
spiritual
of some
provider
sort,
that,
yes.
that
Would you
we
like
can
them to
invite
be
to
called
come
in the
and see
morning?
you or something.
And that brings up
Just-
the
it's a
barrier of the
suggestion.
confidentiality thing with, you know, in the old days, the minister could call and say, okay, who's in,
Yes.
who's on my list?
Who's on my list?
That's so difficult to do these days.
But if I have a family member or a patient say, I go to church, at First United Methodist Church in Rapid City, would you please call the office to tell them that I'm here? I have no problem with calling,
Yeah.
making that call. I hope that that's not an issue, but I feel like if they've requested that,
Yeah.
that it's okay.
I think another thing that we might want to think about is, I think everybody, I mean, you guys have led the way of progressive rounds. You've done a phenomenal job of progressive rounds. But to remember to bring up that question with the patient and family at the time that the progressive rounds are going on. And does Jill still go to your progressive rounds? No? I'm wondering maybe we can check with that because she'll step in and just to speed a light to address many of those issues. And maybe we can see if Jill can meet you with your progressive rounds at least every other day or once a week or something. Because that's the time she can just easily step in and introduce herself and ask for spiritual needs. So.
Well, and to put context as far as from the discipline of spiritual care, if you want to know these things, if not, we can go on. But one thing that's, I think, a perpetual issue with getting support from institutions for spiritual care is like we're not a revenue generating service, which sounds cold, but that's true. And so it's hard, it has been hard for hospitals to justify the cost, especially if you want to give people a living wage and healthcare and like make sure they can actually live. Because I worked as a PRN and it was really hard sometimes whenever all you got was like 3 on-call shifts a month, and so you're trying to make it and you have to do other things. But I think, in Colorado we would use Press Ganey. So there was a question in the Press Ganey that basically said, where your spiritual needs matter, something like that. And what we saw was, like, in our department that we had, 15 chaplains, a patient and family, well, typically family, but sometimes patient, their overall experience with their hospitalization was vastly better if they had support, spiritual support. Even if they were, Denver is full of nuns, like NONESs, people who don't have a religious affiliation. But even those folks, that's a Pew Research term. So there you go. There's your education for the day. But we found even folks who I've had many people in Denver. They heard the word chaplain. They're like, well, I'm not religious. I don't believe in God or whatever. But we could have a conversation, about like, what does this healthcare hospitalization mean to you? How is it affecting your life? How do you make sense of it? How do you move on from this to continue to live your life in a way that is fulfilling as best you can? And those are some of the most powerful conversations for me. And so what we found was even for people who don't have a connection to a religious background or tradition or whatever, or who had been hurt by it, whatever you want to say, just having someone there to provide that support to them helped their hospitalization, helps with their recovery. There's been studies about readmission rates after hospitalization if someone's a spiritual caregiver, a chaplain or whatever. Because really what we're doing, hopefully, is using those resources people have within themselves, whatever they are, to help them make sense of that hospitalization so that when they leave, they can make some sense out of it and then continue their life as fully as they can, which is, I think, as far as palliative care is concerned, is another reason why I think it's important that we get in early and often with patients who you feel could benefit from our services, who your providers feel could benefit from our services, because it's the same thing. You get early, early palliative care services can help mitigate all of those nasty things that come with hospitalization. Pain and symptom management, worldview and existential things, all these things that when we're hospitalized, we don't come to the hospital unless we're giving birth, unless there's a rupture in our lives. Something's going wrong when we're here. And so if we can give patients early and often that good wraparound care for the ones that qualify for, services that we provide, we can help make the quality of their life as good as it can be, as early as it can be. And so I think there's a lot of reasons why we don't have chaplains here right now. And I'm hearing, and this is exciting to me because this is not what I was expecting today whenever we were coming to talk about this, to hear this. Although I've talked to, house supervisors multiple times about this, Jill and I have. And my plug is, the hospital has to hear from you. Like, we can say it all we want. We can tell people, they really need us. Like, there needs to be more. There needs to be 5 of us in a hospital this size. There needs to be 10 of us, really, so we can have 24-hour coverage where people are in the house. If we want to be the best health care system in America to help patients and their families live well, we have to provide all the resources for them to do that. So that's my little plug. It has to come from y'all, not from me, because they're not going to listen to me.
They don't listen to us either.
Well, sure. Okay, well, there's that too.
I wonder,
We just have to keep
interesting angle,
trying.
I think, in that if
if money talks, then maybe that early and often intervention is what will help save 48 hours of crazy intensive care expense. It actually does.
It does make a difference.
Have you seen an increase in your palliative care program? Have you seen an increase in patients with that? And if so, are you able to correlate that to, decreasing anxiety when that patient reaches that point?
You know, the palliative care program has done a great job of seeing patients, and then we keep statistics. Geneva can speak best to the statistics because she likes that statistician part. But what we see are a few things. The most significant that we see is length of stay prior to palliative care and then discharge date. And you'll find that there's a very shortened discharge date once palliative care is on. And it's because there is a huge team effort. And if every physician, if I could give every single physician in this institution, a counselor, a chaplain, a nurse practitioner to work in a team approach every single day with these patients, it makes an impacting difference. And that's really the model that all of us would love to have every day. Now, in the ICU, you guys have truly shined at progressive rounds, and you've really got that team approach going, and your lengths of stay have changed dramatically in the ICUs over the years. But it's integrating that philosophy throughout the system and getting the right people on the teams and making more of these teams available. Because the physicians oftentimes are there by themselves. The hospitalists are trying to manage on their own. And getting people to come in and getting them to see the value of bringing the teams in it just takes time.
We don't see nearly the number of consults from the intensive care unit that I think we should. It's a provider-to-provider consult, so it makes it more difficult sometimes. But I think that still there are many providers in this hospital, not just the intensivists, but many, who believe that palliative care equals hospice. And so you're gonna come in and just tell them that they're gonna die and take them off the ventilator. Well, that's not the case. So it's a struggle. It's a struggle, but we keep trying.
That's been the ongoing, that's not
It is.
like a new concept, or a new problem, it seems like that's
Right,
and it's not just, patients not just in the ICU.
right, exactly.
Accepted into the palliative care
Exactly.
program.
I think we just, we're not progressive enough for it. I mean, like, I went to Magnet 4 years ago, and multiple facilities have actual palliative care teams that work in their ICUs. And like on 24 hours of admission, they make a decision, should we do a consult?